Hello friends, this video is about doing a total knee in a patellectomized patient. There are a few challenges that one needs to understand when we are doing total knee for a patellectomized patient. The most important thing is whether the patient can perform a straight leg raise test, because if the patient cannot perform a straight leg raise, that means the quadriceps mechanism is compromised and should be looked into first before doing a total knee. So that's the first thing. So this 65-year-old man had a patellectomy 12 years back, a total patelectomy, but could perform a straight leg raise. So that means the integrity of the quadriceps mechanism is not compromised and the retinaculum is well preserved. So you can see here that the patient has a complete patelectomy on the left side and end stage arthritis of the left knee. The PCL seems to be intact because you can see that the knee is not subluxed. So we'll discuss the importance of doing a CR knee in a patelectomized patient to prevent anterior drawer when the patient is going downstairs. So you can see there's the original scar and the line of, we'll follow that original incision, and the patient has got varus and some fixed flexion deformity. The important thing again is that the patient should be able to perform a straight leg raise test, as you are going to see. That's the sagittal view. The patient has some fixed flexion deformity about 8-10 degrees and about 10 degrees of varus. We'll be doing a navigated knee. We do a navigated or robotic knee in all our cases, and in this case we'll do a navigated knee through a mid-vastus approach. So there you can see there is no instability and the patient has got a vertical scar there and the range of motion is fairly good. So the most important thing is that the patient has a straight leg raise. So patient has got adequate quadriceps power and integrity of the quadriceps mechanism, and the reticuli is not compromised, and that is why we should be able to do a good total knee there. So you can see that that's following the original incision midline and then doing a mid-vastus approach. The advantage of doing a mid-vastus approach is that the tendon is not cut and hence not compromised, and the recovery is better, and we are not causing any more scarring of the tendon. So you can see that we'll be following a mid-vastus approach. We generally do that for all our cases, but in this case it's especially important not to further compromise the tendon. So you can see that's the mid-vastus approach. We don't use a tourniquet, and the mid-vastus approach will ensure that a thick part of the tendon is available for retraction. So it's very important because there is no patella, so we'll be keeping our homens on the tendon. So that has to be done very gently so that the tendon is not compromised and the healing is not an issue. So we are spending some time exposing the knee thoroughly, meticulously through a mid-vastus approach. So there you can see that we have not cut the tendon but gone through the fibers of the vastus medialis. And then it's easy to retract because the retraction with the homen should not destroy the tendon or compromise the tendon. So you can see there is no patella there. Then we see the offset. We can see that the offset is 18 millimeters, and we'll try and retain or reproduce that same offset in this patient, because the offset is important, especially when you are doing a cruciate retaining knee. So 4 pins, 2 in the metaphyseal area of the tibia and 2 in the metaphyseal area of the femur. The pins are, the first pin is always intra-incisional, the second is through a stab incision on the tibia and the femur. So minimal retraction on the lateral side because there is no patella. There is the deformity after removal of osteophytes. It's 4 degree varus and about 10 degrees of fixed flexion deformity, which will followed by kinematic alignment principles. So we won't do any soft tissue release. That will further ensure that our knee is very stable throughout the range of motion and patient does not have an anterior drawer. So we'll take 8 millimeters of the distal lateral and 6 millimeter of distal medial, so as to reproduce the joint line. So there you can see that it's 8 and 6 millimeters. We'll just check with navigation and not cut more bone than required, so as to reproduce the joint line perpendicular to the kinematic axis of the knee, which passes through the center of the femoral condyle. So there you can see 1 degree of valgus on the femur, and the cuts will measure 8 and 6 millimeters from the lateral and medial side respectively. Then the rotation is 0 again. From the kinematic principle is to cut equal posteromedial and posterolateral. So we are doing a striker knee here, and you can see that we cut equal posteromedial and posterolateral. That again will show in the final measurements. And it's important to preserve the PCL. We normally do a cruciate retaining knee as a go-to in all our cases, but here, especially in a patellectomized patients, it's important, so that there you can see the cuts 9 and 7, 8 and 8, 8 and 8. So all cuts are equal, thence reproducing the joint line in the right orientation of valgus on the femur and varus on the tibia. And that's the basic principle of kinematic alignment. Preserve the PCL, don't do any ligament release, and there you can see the flexion gap is beautiful, trapezoidal, the PCL is preserved, and that's the femur component, cruciate retaining femur, and you can see that there is no anterior drawer, there is no pullback, there is no pull out of the CR insert, maintaining absolute stability in flexion, and that will ensure that the patient does not have an anterior drawer during flexion or getting downstairs. So there you can see the tibia cut is in 2 degree varus and 5 degrees of slope, and that's the way we keep our knee, so that there is no soft tissue release. So normally 1.5 degree valgus on the femur, 2 to 3 degree varus on the tibia will give a good harmonious balance of the knee without doing any ligament release. And there you can see that we have reproduced the offset of around 10 millimeters, and there you can see the mid-vastus approach, beautiful, preserving the integrity of the quadriceps mechanism, and the patient does not have anterior drawer. And you can see the beautiful movement throughout the range of motion. The knee also, the tibia also internally rotates in flexion deformity, and the varus is corrected. That's the range of motion before discharge, about 90-100 degrees. And we'll just show the patient walking nicely, and there you can see the patient walking with some support initially, but after 7-10 days there is no need of support, and the patient would not have anterior drawer, especially because of the cruciate retaining insert. That's the final X-ray. There you can see the kinematic alignment, 2 to 3 degree varus on the tibia, 1.5 degree valgus on the femur. And in the lateral view you can see that the slope is maintained and the flexion of the femoral component is also maintained, 3 to 5 degrees of flexion on the femoral component, 5 degree slope on the tibia. So there you can see that the overall sagittal alignment of both the component has to be good, so that the knee is not tight nor loose in flexion, and very well balanced with a cruciate retaining insert. So those are the 3 important principles of doing a patellectomized knee, a total knee for a patellectomized patient, is to do a mid-vastus approach to ensure that your flexion space is well balanced, to do a cruciate retaining insert, cruciate retaining knee, and correcting the deformity fully with kinematic alignment, so there is no ligament release and the knee is very stable throughout the range of motion. Thank you very much.